Welcome to the deep dive. We often operate under the assumption that, a pill is a pill, and once the doctor writes the script, the medicine works the same way for everyone.
Yeah, but our sources today really challenge that idea, fundamentally.
We are talking about lifespan pharmacology, this kind of profound realization that age and developmental stage, they dictate everything about how the body handles a drug.
Exactly. And this deep dive, think of it as your shortcut into understanding the huge safety differences needed when treating, say, a newborn versus a pregnant mother or someone over 80.
Our mission today is really to see how physiological maturity and then later physiological decline, how they radically alter those four phases of pharmacokinetics: absorption, distribution, metabolism, and excretion, ADME.
The essential ADME process, yeah. And this knowledge isn't just academic, it's really about minimizing harm.
Right, because drug therapy at both ends of life, pediatrics and older adults, it's statistically far more likely to cause adverse effects, even toxicity, compared to the general adult population.
So we need to know what's coming to predict it, to handle it safely.
Okay, let's dive right in then. First up, drug therapy during pregnancy and lactation.
So a fetus is exposed to pretty much everything the mother takes. Prescription drugs, over-the-counters, even street drugs.
Okay, so if someone is trying to conceive or maybe just found out they're pregnant, when is that window of highest risk? For the fetus, I mean.
The forces are really clear on this. The period of greatest danger for those drug-induced developmental defects, it's absolutely the first trimester.
So there's 12 weeks.
Exactly. That's when you have this incredibly rapid cell proliferation happening. The skeleton, limbs, vital organs, they're all developing at their fastest pace.
So self-treatment, even for minor stuff, is really strongly discouraged then.
Strongly discouraged, yeah. And the way drugs get across, that transfer mechanism is mainly passive diffusion across the placenta. It's driven by concentration differences.
Just moving from high concentration to low.
Mostly, yeah, though some active transport happens too. But the amount that transfers is really influenced by the drug's properties. Things like its lipid solubility, molecular weight, how tightly it binds to the mother's proteins.
Okay, now here's something I found genuinely surprising in the research. Kind of counterintuitive, actually. We need to flag this.
What's that?
The greatest risk for those structural birth defects is the first trimester, like you said. But the greatest percentage of the drug that actually transfers to the fetus, that happens during the last trimester.
Yes. That often surprises people.
Why the delay? Why more transfer later on?
It really comes down to the mom's and baby's physiology later in pregnancy. The placenta actually gets better at its job. It has increased blood flow, a larger surface area for exchange.
Okay.
Plus, you often have more free drug, unbound drug, circulating in the mother's system later on. So while the risk of major structural damage might be lower then, the fetus is actually getting exposed to a higher overall dose.
Which increases the risk for accumulation or maybe prolonged effects?
Precisely. Prolonged exposure becomes the concern.
Now, when we're assessing this risk, you, the listener, probably know about the FDA's letter categories, A, B, C, D, X.
Right, the traditional ones. But they're changing.
Yeah, the FDA is phasing those out. They're moving towards new, much more detailed labeling requirements.
It's a good move, I think. More informative.
The new labels have 3 subsections: pregnancy, lactation, and females and males of reproductive potential. And they provide actual data summaries, not just that single letter grade.
Which is much more helpful for clinical decisions. And, the risk doesn't just stop at birth.
Right, lactation. Breastfed infants are exposed to drugs through breast milk.
Yep. And the drugs most likely to get into milk are typically fat-soluble, have a low molecular weight, and are present in high concentrations in the mom.
So deciding whether to medicate a breastfeeding mother requires that careful risk-benefit calculation.
Absolutely. Weighing the benefits of breastfeeding against the need for the medication. Though drug levels in breast milk are generally lower than in the mom's circulation, the risk isn't zero.
Okay, let's shift gears completely now. If immaturity is the issue for the fetus, how does that same kind of immaturity affect pediatric patients?
Big topic. And we need clear definitions first.
Right, so neonate is less than a month old, infant is 1 to 12 months, and a child is 1 year up to 12 years.
And the differences in how they handle drugs, it's all based on the fact that their systems just aren't fully mature yet. Nothing's running at full capacity.
Let's start with absorption. Why do oral drugs act so differently in a baby's stomach?
Well, think about it. The cells that produce stomach acid, they're immature until about age 1 or 2. So the gastric pH is less acidic.
Okay, less acidic.
Gastric emptying is also slower, And importantly, that first pass effect where the liver breaks down some of the drug before it even gets into the main circulation that's reduced.
Because the liver's immature too.
Exactly. The liver enzymes aren't fully functional yet.
Now, distribution. You mentioned this is where immaturity really has acute consequences.
It really does. An infant's total body water is much higher, like 70, even 85%, and their fat content is lower. But the most significant challenge, protein binding.
Okay, let's use that analogy you mentioned earlier. If protein is like the drug's delivery service, or taxi.
Yeah, the taxi analogy works well. If protein is the drug's taxi, infants and young children just have fewer taxis available because their liver isn't producing enough protein yet.
So fewer taxis means?
It means decreased protein binding, and that results in much more unbound active drug just circulating freely in the bloodstream.
And only the unbound drug can actually have an effect.
Exactly. So less binding directly translates to potentially dramatically enhanced drug effects, more bang for the buck, but also much higher risk.
And then there's the blood-brain barrier issue, too.
Right. That barrier is also immature, less effective, so more of that active drug can cross into the central nervous system.
Wow. So more active drug, fewer Paxes to bind it up, and less protection for the brain. That sounds like a recipe for toxicity if the dose isn't spot on.
It absolutely is. Extreme caution needed. Now, let's quickly cover metabolism and excretion.
Yeah.
Metabolism is significantly slowed. Again, that immature liver has lower levels of the microsomal enzymes needed to process drugs. This makes the drug hang around longer, prolongs its half-life.
And excretion. The kidneys.
The kidneys are the bottleneck here. The glomerular filtration rate, or GFR, that key measure of how well kidneys filter waste, is decreased.
Because the kidneys are immature, too.
Yep. So drugs are cleared much less effectively. This leads to drug accumulation. Things just build up.
Okay, so beyond just how the drugs move through the body, there are also some drugs that are just flat out contraindicated, right?
Right.
Because they interfere with growth.
Yes, absolutely. This adds another critical safety layer. For instance, everyone knows tetracycline antibiotics are a no-go for young kids.
Causes permanent tooth discoloration.
Right. And systemic corticosteroids can actually suppress growth. Certain quinolone antibiotics are also generally avoided due to concerns they might damage growing cartilage.
Which brings us, inevitably, to the absolute most critical safety point for pediatrics, dosage calculation.
Cannot emphasize this enough. Since so many drugs don't have specific FDA approval or guidelines for kids, precise calculation isn't just recommended, it's mandatory.
And the standard method is milligrams per kilogram, mg/kg of body weight.
Universally used. And this is where mistakes can be catastrophic.
You mean like mixing up pounds and kilograms?
Exactly. If you, the practitioner, forget to convert pounds to kilograms, just divide pounds by 2.2, you could instantly create a toxic overdose, a simple math error with deadly consequences.
So the safety process has to be rigid.
Absolutely. Calculate the patient's weight and keel gene, find the usual dosage range, mg/kg day or maybe mg/kg dose, calculate the minimum and maximum safe dose for that child, then compare it strictly against what's prescribed.
And if there's any doubt, any discrepancy,
You stop. Immediately, you pick up the phone and contact the prescriber. No guessing allowed.
okay. And what about actually giving the medicine? Any practical tips there?
Yeah, some crucial ones. Never, ever mix medication in essential foods. Things like milk, formula, cereal.
Why not? Seems convenient.
Because the child could develop an aversion to that food. They associate the taste of the medicine with their breakfast cereal, and suddenly they refuse to eat it. You don't want that.
Good point. And the other big one,
The candy thing. Never refer to medication as candy to try and coax a child.
sets a dangerous precedent.
Terribly dangerous. You have to establish clearly that this is medicine, it needs respect, even if you have to explain its purpose in very simple terms suitable for their age.
Okay, now we pivot to the other end of the lifespan spectrum, the older adult patient, generally defined as 65 and older.
Right. And if immaturity was the core issue with kids, here the problem is more about systemic decline, and very often just dealing with an overwhelming number of medications.
The demographic growth here is huge,
Mm.
right? This population is expanding rapidly.
It is, and that leads us directly to polypharmacy. It's a massive challenge.
Define that for us again.
Polypharmacy is just the concurrent use of many different drugs. Often the threshold used is 5 or more, but it can be many more than that.
And taking that many drugs just skyrockets the risk of adverse reactions, drug interactions.
Absolutely. The more drugs you add, the higher the probability something will go wrong. And this leads to something fascinating called the prescribing cascade.
Ah, tell us about that.
It's this cycle where an older adult ends up getting a new drug specifically prescribed to treat the side effects, maybe dizziness, confusion, constipation caused by another drug they're already taking.
So you're treating the side effect of one drug with another drug, which probably has its own side effect.
Exactly. It can become a vicious cycle. This is why the universal dosing advice for older adults is start low and go slow.
Meaning you often begin with a much lower dose than standard.
Often, yeah, maybe 1/2 to 2/3 of the standard adult dose, and then you increase it very gradually, monitoring closely, because we have to factor in the dramatic changes across ADME again.
Okay, let's walk through ADME in older adults. Absorption first. What's declining?
Several things. Reduced hydrochloric acid production means the stomach pH is less acidic. GI motility, the movement through the gut, slows down quite a bit.
Things just move slower.
Right. And crucially, blood flow to the entire GI tract can be reduced by up to 50% by age 65. Less blood flow means less efficient absorption of the drug from the gut.
Got it. Now, distribution. How does the body's composition change?
It changes in the opposite way from infants, mostly. Total body water decreases,
Okay, less water overall.
which can lead to higher concentrations of water-soluble drugs, think many common antibiotics. That increases toxicity risk. Conversely, body fat percentage tends to increase.
And that affects fat-soluble drugs.
Yes, it prolongs their action. Things like sedatives or hypnotics can hang around longer because they get stored in that increased body fat.
And, just like we saw in pediatrics, protein binding is an issue again. Albumin.
Yes, a key issue. Reduced albumin production by the aging liver means, once again, more unbound active drugs circulating freely.
So drugs that are usually highly protein-bound, like warfarin or phenytoin.
Their effects are enhanced. The patient becomes much more sensitive to standard doses, increasing the risk of bleeding with warfarin or toxicity with phenytoin, for example.
Okay, let's talk about the clearance engines. Metabolism and excretion. How much do they slow down?
Significantly. Metabolism declines because the liver mass itself might shrink, and liver blood flow is significantly reduced. Estimates are around a 1.5% reduction in blood flow per year after age 25.
Wow, that adds up.
It really does. So, smaller liver getting less blood supply means reduced production and activity of those crucial microsomal enzymes. It takes much longer to process a standard dose.
Which prolongs the half-life, leads to accumulation.
Exactly. Drug accumulation is a major risk. And the kidneys, they take a big hit too.
How bad is the decline in kidney function?
The glomerular filtration rate, GFR, can decline by 40 to 50%. Again, due to decreased blood flow and just fewer functioning nephrons, the filtering units.
40 to 50%, that's huge.
It is, and this delayed drug excretion is extremely dangerous, especially for drugs with a very narrow safety margin, what we call a low therapeutic index.
Like digoxin?
Digoxin is a classic example. Small changes in blood level can lead to toxicity, so impaired kidney function is a major red flag.
So safety and monitoring become absolutely paramount. We have to watch kidney function labs.
Key markers like serum creatinine and BUN, blood urea nitrogen,
Yeah.
and liver function tests like AST and ALT.
But you mentioned a really important clinical pearl about creatinine.
Ah, yes, this is critical. Serum creatinine levels can sometimes be misleadingly low in frail older adults, especially those with very limited muscle mass.
Why is that?
Because creatinine is a byproduct of muscle metabolism. Less muscle means less creatinine produced, even if the kidneys aren't filtering well. So a normal creatinine level might actually be masking significant underlying renal dysfunction.
So you can't just rely solely on that number, especially in a frail patient.
No, you need the whole clinical picture, maybe estimate creatinine clearance using formulas that account for age and weight. This reliance on careful assessment leads us straight to the Beers criteria.
Okay, tell us about the Beers criteria.
It's an essential tool, basically a list, updated regularly by the American Geriatric Society. It identifies potentially inappropriate medications for older adults. Think of it as a critical safety checklist.
What kind of drugs does it flag?
Common culprits include things like opioids and other CNS depressants because they dramatically increase the risk of falls and confusion. NSAIDs due to renal toxicity risk. Anticholinergic drugs, notorious for causing confusion, dry mouth, constipation, urinary retention.
So it helps prescribers and pharmacists flag these high-risk meds.
Exactly, it prompts a review. Is this drug truly necessary? Is there a safer alternative?
Now, to manage that polypharmacy risk, just figuring out what the patient is actually taking can be a challenge.
Oh, absolutely. Patients might forget things, or not mention over-the-counters or supplements.
So what's the best technique for getting a truly accurate list?
The gold standard is often called the brown bag technique.
Simple enough.
It really is. You just ask the patient or their caregiver to literally bring everything they take, prescriptions, OTCs, vitamins, herbal supplements, everything in its original container to their appointment or hospital admission.
Then you can see exactly what they have, the doses, the instructions, no guesswork.
Precisely. It's the most reliable way to get a complete picture. And one final patient safety note related to drug administration.
Yeah.
Always be mindful of transdermal patches. Things like fentanyl patches, nicotine patches.
What's the specific risk there?
Because they contain a reservoir of active drug, if a patch accidentally falls off maybe onto bedding, clothing, or the floor, it still contains potent medication.
And could be picked up by someone else.
Exactly. There's a serious, toxic, even fatal risk if a small child or an infant finds a discarded or dislodged patch and puts it in their mouth or even just handles it. Careful disposal and awareness are key.
Wow, okay. We have really covered 3 drastically different physiological landscapes today. Pregnancy, then the rapid growth and immaturity of childhood, and finally the systemic decline in older age.
And the take-home message is just how much the body's changing capacity demands radically different approaches. Dosing, monitoring, everything changes.
The difference between what's a standard adult dose and what's safe for a child or an older adult. It can be tiny fractions, but the consequences are huge.
It really underscores the need for precision. And if we connect this all back to the bigger picture, thinking about that high prevalence of polypharmacy, the dangers of that prescribing cascade, it raises an important question for you, the listener.
What's that final thought?
Given all this physiological variability, all the risks of adverse events, how might just emphasizing and really implementing simple, non-pharmacologic interventions, things you do before even reaching for a prescription pad, how might that serve as the most crucial foundational safety measure against drug toxicity across every single age group? Something to think about.
A really powerful closing thought. Thank you for joining us for this deep dive into lifespan pharmacology. We hope this knowledge helps you navigate drug administration across the entire age spectrum with maximum safety.